Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we get to have the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and today I am joined by Dr. Liz Layne. Dr. Layne is a dermatologist at Blue Pearl Pet Hospital in Midvale, Utah. And she and I are going to be talking today about her top recommended topical treatments. Specifically, we're looking at topical treatments in the realm of how can we reduce or limit our use of systemic antibiotics for some of our challenging dermatology cases. One of my mentors said a long time ago that one of the best things about the skin is that it's on the outside of the body, right? Like, meaning it's so accessible, unlike the liver or some other things, it's right there. And so that really lends itself to topical therapy. And so, we do have all of these options and things like shampoos, sprays, wipes, all of those come to mind. But there are some other, exciting novel treatments out there. And I'm really looking forward to talking about those with Dr. Layne today. So thank you so much for joining us. We are thrilled to have you here today. Before we get started about talking about your top 5 therapies, I was wondering if you could introduce yourself to the audience, let us know a little bit about your background.
Yeah, thank you for having me, Alyssa. I was excited to get this invitation. As you said, I'm a dermatologist in Salt Lake City, Utah. Prior to this, I had spent 11 years in general practice in my home state of Montana, both mixed animal and small animal. So I feel like I have a lot of sympathy for the day-to-day that small animal veterinarians are going through. And there's so many innovations, so many new things, new medications, new treatments for all of the body systems. I have a lot of admiration for the general practitioners who are keeping up on all of that. So I really appreciate these invitations from Clinician's Brief to try to bring a little clarity, maybe some simplicity to what's already a very busy, complex job.
Yeah. That is absolutely, what we aim to do, not only with our, our website and our print journal, but also, here on the podcast is kind of breaking this down. And certainly I, as a general practitioner, really appreciate the chance to just sit down and pick your brain about a lot of these things because they are coming, like you said, just so fast. I know certainly one of the treatments that we're going to be talking about, I think, after the break is one that I don't have a lot of experience with, and that's the fluorescent light therapy. But we'll get to that in a little while. We're gonna start a little bit more mainstream, something I think a lot of us have experience with. I certainly do, and that's topical antiseptics. Okay, and so when we're looking at superficial pyoderma, and we are thinking about leveraging our topical therapies in order to maybe, reduce the use of systemic antibiotics, maybe leave that cephalexin or the cefpodoxime on the shelf, why do you feel like chlorhexidine is considered, a really excellent topical antibactericidal for this type of patient?
It has the best evidence, to put it plainly. It has the most studies supporting that it is the most effective at killing staphylococcal bacteria. It's widely available too. There are a number of other products with, maybe accelerated hydrogen peroxide or stabilized bleach, but they don't have as much data. In Europe, there are a couple of other compounds, but we don't have those available. So for the best evidence in North America, in the US, chlorhexidine has the best evidence supporting it. And now we have a huge variety of products that contain it. So there's really no reason to not use it unless a pet or an owner has a chlorhexidine topical or contact hypersensitivity to it, which we can get into a little bit. But chlorhexidine really is like the workhorse of topical antiseptic therapy.
That's a really good point about the fact that not only do we have to think about could our patient have a reaction or a bad reaction to a topical therapy, but also our owners are going to be applying these and oftentimes, are applying them without gloves or things like that. And so to just keep that at the forefront, we'll talk a little bit to you about how to counsel owners, because that's another thing we want to make sure, I know for myself, sometimes when I lay out, I want you to do these baths and these wipes and all of these things. Sometimes my owners can get a little bit overwhelmed. So we'll talk a little bit about compliance too. I do want to talk about, you said there is a lot of evidence for chlorhexidine, and there's a lot of these different products, like you said. Some of them are in combination with an azole antifungal. And so I was just wondering if you could give us your opinion on which one of those you prefer, and what cases we should be looking for, not just chlorhexidine, but maybe combining that with another product.
Yeah, there are so many products out there. And I think back to when I was in vet school 20 plus years ago, and we had a couple of shampoos, and now we have zillions of them with very slight differences in ingredients. So I think it's hard to choose, particularly, if you're trying to manage the inventory. Do you carry 8 different shampoos or 3? There is really one shampoo that I use almost all the time. It's a chlorhexidine plus miconazole shampoo. And the reason being that miconazole has anti-staphylococcal activity too. So miconazole plus chlorhexidine are synergistic at killing staph. So you're almost never going to go wrong using that product. Obviously, if there are Malassezia yeasts on the skin, then adding an azole antifungal is very useful too. Part of the other thing to look at with formulation is, are they also degreasing or descaling? Because a lot of allergic pets who have pyoderma, they're really greasy. Owners see the scale and the yellow crust, and their eyes see it and say, oh, that looks dry. But if when you pet the dog and you examine the dog, your fingers come away greasy, they're not dry, they're greasy. So they need a degreasing and descaling shampoo. And part of the benefit of that is the grease is part of the food, if you will, for the yeast and the bacteria. So if you're removing some of the food source, physically removing the organisms and killing them with your ingredients, you'll have a much better response. So personally, I have one chlorhexidine miconazole shampoo that I use almost exclusively for, there's a couple other conditions that maybe don't have infection as a component, and there are other shampoos I'll use for that. But particularly dog skin and even cat skin, and we can talk about shampooing cats. Dog skin is so prone to overgrowth of normal flora when it's diseased on any level that almost every pet with skin disease needs a disinfectant or antiseptic shampoo, and that combination is my personal preference.
And then how often are you applying those? It's another question I get all the time from owners. How often is too often to bathe them? And so is there something, can you bathe them too much? How often can these products be safely applied? And contact time is another one that I get a lot of questions about. How long do we need to be leaving the shampoo on the skin in order for it to do its job?
Yeah, boy, these are areas where we could use so much more research, but it's not exciting research, right? Like, who wants to fund the study of, well, we're going to do 1 minute contact time, 5 versus 10, and how do you define that? Is it the minute the shampoo touches the skin? Is it after you've lathered it all? Shampoo studies are actually much more complicated to do than you think, because how much shampoo, how much water, coat type, all of that. Yeah, so how often? If a pet is tolerating it well, so if they tolerate a bath, the general guideline, and there's 1 or 2 studies that support this, is to have an antiseptic bath 2 times a week with application of an antiseptic spray daily on non-bath days. And this is for about 4 weeks to treat superficial pyoderma. That's intensive. That is a lot of work on an owner's part. It's much easier in most cases to just give a pill. But as you mentioned, we have got to be doing better with our antimicrobial stewardship. We are, in the US, we are way behind as a profession where the rest of the world is. There's the World Health Organization Antimicrobial Resistance Week coming up at the end of October. So I think veterinarians in particular really have got to be thinking, okay, it's got pyoderma. What are the factors for this pet that I can, or that would make it amenable to topical therapy? Because our antibiotics just won't work. And as you said, the skin's on the outside. You can't shampoo the bladder, you can't shampoo the lungs, and you want to save your antibiotics for when those systems are affected, because you can't really do topicals, whereas we can on the skin. And I find a lot of owners are sympathetic to that. If I talk about superbugs or the evolution of antibiotic resistance. A lot of them understand that. So that's my first step into saying, let's do this topical regimen. Now, contact time, that's another big question. All of the shampoos will say 10 minutes, but if you dig down deep trying to find where that comes from, I've never been able to find an origin story for where 10 minutes contact time comes from. So I find sometimes that owners will say, yeah, my vet told me to do this shampoo, but I can't leave it on for 10 minutes. That's just impossible. So I didn't do it. Well, it's better to do some than none. So you say it would be ideal for you to spend 5 or 10 minutes really lathering and scrubbing. But if you can't, do the best you can. Twice a week shampoo is ideal, but if you can only get once a week, do it. If you can only get once every 10 days, okay. Obviously, a long-haired, large breed, rambunctious dog belonging to somebody, with physical limitations, whether they're elderly or they just had shoulder surgery or, you name it, that dog's not going to be a good candidate for just intensive topical therapy. But most owners, when you talk to them about resistance and trying to avoid using antibiotics in their pet, I think a lot of them are open to it. And oftentimes what I'll do is I'll say, let's try this regimen for 2 weeks and then call me or email me. If it's too difficult, if your dog won't tolerate it or you're not seeing any improvement, then we'll start an antibiotic. That's fine. But oftentimes if they can really commit, they'll start seeing a lot of improvement in that 2 weeks and they feel like they can keep going.
That's a very great point. And I like having that kind of micro goal, set out a couple, week or two in a small chunk just to see, so that we don't say, yeah, we're going to be doing this, for months or the rest of his life, And I think too, just like you said, really communicating to clients. This is something that I've learned as I've gotten deeper into my career, is to try not to make assumptions about who can do what or what's going to be difficult for a client. We really need to ask them, because sometimes I'm surprised at things that I think would be easy that is too difficult for a client, just because of, like what you said, something going on in their life that we have no idea about, chronic pain or a surgery or something. And other times, things that I think would be really too difficult, a client says, oh no, that's easy. I can do that, no problem. So keeping those things in mind.
Yeah, that's exactly right. I am continuously surprised, these big dogs and owners say, oh no, he loves the shower. We shower
Yeah.
every day anyway. And that goes for cats too. So cats get superficial pyoderma, they get Malassezia dermatitis. And I say to owners, now I'm going to ask you a question. Laugh at me if you will, but do you ever bathe your cat? Do you
Mm-hmm.
ever shampoo your cat? And they either say, oh my gosh, no, he'd rip my face off. Or they say, oh yeah, we already do twice a month anyway. And I go, great. So it's worth asking. And you can make it humorous because a lot of people think you're totally bananas for asking if you can shampoo your cat. But you will be surprised at how many cats are getting baths regularly.
Mm-hmm. Let's move on to your next category, which is topical corticosteroids. Just like the antiseptics, these are available in all sorts of forms. There's human products, there's over-the-counter products. I've had animals come in and the owner has been just lathering them up in hydrocortisone cream without my knowledge for weeks. So they do offer benefits and over systemic corticosteroids, and oftentimes we think they have fewer side effects, but they are not totally without risk. And so what precautions do we need to take, particularly when we're prescribing some of the more potent steroids? I know, I've been in practice for 20 years, and the Gentacin spray, combination gentamicin and betamethasone is an old favorite that I've had people come in and they have a bottle that's been sitting under their counter for 10 years that they pull out and use sometimes.
Yeah, it's a classic product that I used to use quite a lot, and now it's one thing when owners bring it in, I just throw it in the garbage can. Yeah, there's a couple of things. So if you can avoid systemic steroids, that's also good, not from an antimicrobial resistance standpoint, but just from an adverse effect standpoint. So you might be using a different medication to control allergic itch, but there may be one or two body regions that just aren't well controlled. And I particularly see that with the ears and with the paws. And they're not infected, they're simply inflamed. So a topical steroid can be really useful in that those are limited areas where you can apply a steroid. They give the benefit without all the side effects. The places where people get into trouble is with when there's more widespread disease, and particularly on skin that's quite thin to begin with. So one of the adverse effects of topical steroids is skin thinning or atrophy of the skin, because it slows down the turnover and it decreases collagen production. So if you think about where allergic pets are typically affected, both with just itch and inflammation, but then where they get pyoderma, it's their inguinal and axillary skin very commonly, already very thin skin. So if you prescribe a spray that's got an antibiotic, perhaps gentamicin, and a steroid, perhaps betamethasone, the gentamicin will probably kill the bacteria readily, and the betamethasone will take care of the inflammation. If the owner continues with it, the skin begins to thin out, or they stop using it because the problem's resolved, but if the underlying allergic inflammation isn't controlled, the rash comes back, they spray some more, goes away, comes back, they spray some more. Every time they're thinning out that skin, it gets thinner and thinner. When skin thins to the point of failure, it's a red, rashy looking skin. So the owner applies the spray even more and more and more. So you get into this sometimes severe skin atrophy. They get comedones, they get milia, they have erosions, they can have very deep ulcers, and the owners don't realize that they're making the problem worse. There is also concern, although it's not really well characterized, with antimicrobial resistance to the gentamicin. So my personal preference is to decouple the two, because you want to use a steroid enough to get the problem under control and then infrequently enough to keep it controlled. Whereas you don't want to use an antibiotic here and there. You don't want to use it 3 times a week, but maybe you want to use a steroid 3 times a week. So that's where I replace that with chlorhexidine shampoo to kill the bacteria. And then there are products that are steroid only. There's triamcinolone spray or cream, and use that to keep the problem under control. So it's really that skin thinning and teaching the owners, hey, you've got to use this until it's resolved and then periodically for control. Personally, I don't use topical steroids on the underside of the body very much because that skin is so prone to that thinning out. But paws, pads are very thick, paw skin, ears, other regions, they're very useful.
Yeah. I've definitely seen some studies recently about using topical corticosteroids with, no antibiotic in them and things like that in the ears for these chronic allergic otitis cases. And I think the cytology that followed up on them showed lower organisms. So that was really neat. So atopic flares is one thing. Are there other times that you're using these topical corticosteroids, besides allergic dermatitis?
Yeah, a lot. There's a lot of things. So, interdigital furunculosis, whether it has an underlying allergic cause or whether it's anatomical, a lot of these bully breeds with inguinal limb deformity and these very fleshy feet. So, a lot of them will use either triamcinolone spray or cream, and it's long term. They get their cream 3 times a week for the rest of their lives because we can't correct this anatomical defect. I live at relatively high elevation in a very sunny place. I see a lot of discoid lupus, facial lupus, so steroids can be useful for that. Although you can also get into the skin thinning, kind of looks like the lupus lesions. So there's a balance to be found there. And then even for diseases like pemphigus or chronic cutaneous lupus, if there's 1 or 2 spots that just won't heal, but the rest of the lesions have healed and we're tapering the systemic medications, I'll often use a topical steroid for those couple of problem spots.
And then I think it's important to think about other types of infections too. We said we oftentimes are using these products when there's mild bacteria or yeast pyoderma, and we need to address those with our chlorhexidine or something similar. However, I have seen cases. I remember a case, like I said, where the owner brought the dog in and they had been using a over-the-counter hydrocortisone cream all over the dog for a couple weeks. And this poor dog, when I looked under the microscope, it was wall to wall Demodex under the microscope. And so we really need to be careful when we to remember these other things: parasitic, dermatophytes, viral skin infections too, I believe. And so if we do have a patient that we have on these long-term, low dose or infrequent steroid treatments, how often do you recommend bringing them in and doing things like cytology or skin scrapes in order to monitor them?
It is really important to remember there are other skin diseases besides allergy. You're totally right. I think it's easy because, I don't know, 95% of the pets you might see in a day are probably allergic. And it's easy to just kind of keep cranking through and go, yeah, that. But there are other skin diseases. So I think one, it does start with doing a complete diagnostic workup, ruling out demodicosis, examining what's your index of suspicion for dermatophytosis. Although sometimes, again, if in the acute phase of treatment of those diseases, either demodicosis or dermatophytosis, they can be quite pruritic. So a little bit of topical steroid for a week or 10 days might be appropriate. Um, in If you're using them long term to control allergic disease, you probably should be rechecking those dogs at least twice a year, maybe more, depending on what systemic therapy you're using. And I don't know that necessarily you need to be doing skin scraping or cytology on normal appearing skin, but really looking at the skin and questioning the owners: how often are you using this? How well is it working? And then anytime you have a lesion, you always have to remember, okay, we are using a steroid. Is that suppressing the local immune system? Do we have an infection because of that? Or do we have an infection because the allergy is flaring? It can be tricky sometimes. Viral papillomas, certainly in dogs, are a thought. I don't know that that's as common related to topical steroids, but any of the systemic immunomodulation could allow those to occur. And then cats too. Um, Cats are not as amenable to sprays and creams as dogs might be. But again, if you don't ask, you don't know. And they certainly, around their face, maybe herpes viral dermatitis,
Mhm.
that sort of, flare up would be something to consider. And it can also mimic an allergic flare up. So it's just a good challenge for you.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serraline Moxidectin and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serraline or belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
We alluded to this therapy at the top of the episode, and this is one that I'm so excited to talk about. I want to talk a little bit about fluorescence biomodulation. And so this is also called fluorescent light therapy. And this is a newer therapy. It is not one that any of the clinics that I work for, I haven't had a chance to actually use it on a patient, although I've seen it demoed, at several different conferences and things like that. And so could you just speak a little bit about how fluorescent light therapy works? I realize that there are some differences between that and kind of the more traditional class 3 and class 4 therapeutic lasers that I think a lot of our audience is familiar with.
I will start by saying I'm not a physicist, so I don't fully understand. So in the kind of theoretical explanation, the laser is a monochromatic, so it's one very specific wavelength and color of light. And obviously the power or strength of it varies. So the class 3 is sort of the cold laser, is what some people have call it, or therapeutic laser. That does have some benefit for wound healing, arthritis, tendon injuries, I believe.
Mm-hmm.
Class 4, my understanding, are the surgical lasers, which are cutting. So that's a completely different category because they're very high powered. But the fluorescence photobiomodulation or fluorescent light therapy, or however it's called, a couple of different things by different authors. It's different in that it's polychromatic, so it's multiple wavelengths of light. It's a wider wavelength. And so the idea is that it penetrates differently into the skin than that single wavelength, perhaps deeper and getting different energies deeper into the skin. There's a surprising amount of literature on light therapy in the human dermatology realm. Blue light treatments for acne have been around for 20 or more years, and that's been FDA approved. There's also different light therapies for different types of skin cancer. And then every woman of our age is being marketed these red light, infrared wands, and masks for anti-aging. And there is evidence that deep red light stimulates fibroblasts to produce more collagen, so that would plump up your wrinkles. So there's actually quite a lot of data on the human side for the benefit of different kinds of light therapy for different skin diseases. In the US, we have a system called Fovea by Vetoquinol, and it has this photoconverting gel, which converts the energy of the fluorescent light in the lamp to penetrate the skin better. There is some data for it for post-surgical wound healing, so I think it was a TPLO study, and those incisions healed faster when they are treated with Fovea than without. There is also some evidence for it being antibacterial. The in vivo data is better than the in vitro, and this is where it's difficult to study because bacteria on the skin are different from bacteria in a petri dish with the gel and all of that. But what's really exciting about it is it can be used to treat focal pyoderma quite nicely, a lot of inflammation and wounds. So maybe we can avoid systemic antibiotics by using a treatment that's not only going to reduce the infection, but speed healing as well. So that's what I find most exciting. Dogs tolerate it pretty well. I've been using it in cats. They also tolerate it pretty well. So it's worth a lot more research, and it's worth kind of investigating.
Mm-hmm. Do you know, so obviously it comes with, just like you said, the gel, and you spread, a thin layer of the gel on, and then it has the special LED lamp that emits the light. Is there any other special equipment, or do we need any personal protective equipment in order to do it, like goggles or gloves or things like that, we kind of consider with our other laser therapy?
Yes, you definitely need goggles. They're special orange colored glasses, because it is quite a bright light, so it could cause eye damage. And you do need a little tongue depressor to spread the gel on, and it's wiped off with saline. I usually wear gloves because I'm usually handling something that's infected or an open wound. One of the nice things about it is you kind of move it with the pet. It doesn't need to be held precisely over the treated. I mean, it obviously needs to be over the treated area, but a therapeutic laser has to be held at a 90-degree angle and really held closely for a long time over the treatment area. Whereas the Fovea, you're kind of moving around with the dog, and because they sometimes don't hold still, as we all know. So it feels a lot more flexible and kind of manageable. It's also only 2 minutes per session, so that's pretty tolerable. But yes, definitely glasses.
Definitely glasses. Do the patients wear protective eyewear as well?
Yeah, thanks for bringing that up. It depends on where we're treating. If we're treating a hind leg, we just have, the technician hold their head away. If it's getting close, we will use one of those calming caps
Mm-hmm.
that covers their eyes. And then if we're treating something on their face, we'll use a corneal shield. So we use proparacaine to numb their eye and then put a shield in there so that they can't, it's completely blocked.
Yep. Very good point about safety. Speaking of safety, are there any other contraindications? I know that this is something, like you said, we're still really investigating. I think there's, like many new therapies, there's going to be people that try it for all sorts of things. But can it safely be used in cases of neoplasia or autoimmune diseases? Pemphigus comes to mind.
That's all to be determined still. I would not use it in neoplasia unless perhaps I removed a tumor and then wanted to use it on the incision, particularly cancers that are solar related, so
Mm-hmm.
squamous cell carcinoma, cutaneous hemangiosarcoma, even actinic or solar dermatitis. I would not use it on those wounds because those are induced by light damage, so I wouldn't want to give any more intense light. For autoimmune diseases too, some of them are worsened by ultraviolet radiation. Now this is fluorescent, this isn't ultraviolet, but I think that intense light maybe could worsen them. So I think about like DLE, for instance. I don't know that I would ever use it on that. Something like pemphigus, though, I'm curious. I don't know. Somebody's probably doing it, and I hope they write it up. It covers about probably, I think it's a 15 or 20 centimeter in diameter area. So it is limited in the regions. You could spend a lot of time doing a large body surface area. So for widespread disease, I don't know that it would be that practical. But I hope somebody gives us more information about pemphigus. There was one case report using it for calcinosis cutis. They started it because of the pyoderma, but it did appear to induce faster resolution of the calcium in the skin. So that was interesting.
That is very interesting. And I can definitely understand why you'd want to be more cautious with diseases that are associated with solar induction. So let's move on from that one and talk a little bit about the barrier function that our skin serves and how can we help support that barrier function. So we know we have our epidermis, our dermis, our hypodermis. Our skin keeps contaminants out, it keeps moisture in, but this barrier, as I think you said earlier when we were talking about atopic disease, can get disrupted, anytime we have skin disease. So what products are out there available? What are your favorites to help us restore that barrier function of the skin?
There are so many now, right? Which is great. Again, we had so few choices in the past, and now we have a lot, but it can be overwhelming.
Mm-hmm.
I think first it's important to make sure there isn't infection on the skin, because you can put all the ceramides or fatty acids on the skin you want, but if there's really fulminant pyoderma, you won't see improvement. But once you have the pyoderma controlled, if this is a dog who maybe is particularly dry, then using topical, so there's ceramides, phytosphingosine, fatty acids. Those are in various combinations, shampoos, sprays, spot on too. And this is, again, the owners of an atopic dog are doing 3 or 4 or 5 things. This might be the 5th or 6th thing. So maybe not every pet gets this, but if the owners really want to do more, if they want everything, they've got it all under control, then you say, let's add some of this barrier repair to see if we can prevent those flare-ups by helping the epidermis stay sort of closed, stay smooth and tight so that the allergens aren't getting in there. Other disease that I really like these for is sebaceous adenitis, which my colleagues and I think is increasing with all the doodles around. There used to not be a lot of standard poodles, but now that just about every dog is mixed with a standard poodle, we see a lot of this. So once you have the pyoderma controlled, you have all this scaly, dry skin that's got a terrible imbalance of fatty acids. So adding topical fatty acids in whichever form you choose and that they will tolerate can be really useful in helping that coat normalize and then preventing more pyoderma. So these are not a first line treatment, but they're the more chronic maintenance, long-term, low side effect products that can help reduce the amount of antiseptic and hopefully antibiotics you need in the future.
And my understanding is some of these products are just already included in some of the shampoos and things like that we're using anyway, which is nice.
Yeah, that is true. Yeah.
The final topical that we're going to talk about and was featured in your article is honey. And honey is so amazing. And there's been a lot of, I think, renewed emphasis on honey, especially managing wounds and things like that. So what are some of the benefits that medical honey has to offer?
I love reading on honey because every article starts with, it's been used by humans for centuries, millennia, ancient. And that is true, which is cool. What's old is new. Honey, so it's the only concentrated sweetener found in nature is one article I read. So it has an incredible osmotic capability. So it has very high osmolarity, so it's drawing water out. So it can simply kill organisms by dehydrating them, for one. It's also drawing edema out of wounds. So honey's not going to obviously be practical for superficial pyoderma. You're not going to spread a dog with honey because, my goodness, what a mess. But particularly for wounds, whether these are lacerations or burn wounds or a dehisced surgical incision or laser ablation and you're leaving an open wound to granulate, there's a lot of benefits. So antibacterial, there are antimicrobial peptides in honey too that might be killing bacteria. Because it provides a nice thick barrier, it's keeping the wound moist, which enhances healing. A lot of the properties depend on what flowers it's made out of too. So a lot of people have heard of Manuka honey, which is the Manuka flower in New Zealand, and it has a particularly high concentration of certain phenols that are antibacterial and that can reduce reactive oxygen species and all kinds of benefits. It all depends on the flower and the processing too. So there's different studies that have use different honey, so it's hard to compare them. But overall, it can be quite beneficial.
And then I have seen studies where honey has been used in the ear canal to treat otic infections. Just curious about that because, kind of like you said, spreading honey all over your dog seems like not such a good idea. And it seems very messy to me, or a little odd to put honey down the ear canal. But I wondered what your opinion on that was.
Yeah, like you have this vision of that like plastic bear-shaped bottle of honey with the little yellow lid and just squeezing the honey bear in the dog's ear. No, that there's one study that I'm aware of. It was pretty small, like 15 dogs, and they had a special honey-based gel that they used. They didn't describe their packaging, but I'm sure it was in a tube of some kind. Because you're right, you're not just pouring honey down a dog ear. I mean, that would be really difficult, and that's the challenge is that honey's natural formulation is not very practical for use. So, but in that little study, I think it was like 10 out of 15 or 12 out of 15 dogs after even just 2 weeks, their cytology was negative and their ear had healed. So I think depending on the formulation and the product type, it certainly has some possibilities. For wounds in particular, there are medical honeys that have been mixed with stabilizers and other ingredients, so they're easier to spread. But if you leave the tube uncapped a little bit, it crystallizes just like honey on your counter. So yeah, I don't think we're going to be having like honey mousse or honey spray or honey wipes anytime soon because it's just a mess. But I would not be surprised if there is a honey-based ear product soon. And then there are already numerous wound, either bandages, hydrofilms,
things you can pack into an area or something like that. Seems like a more accessible way to use that product.
Yeah, there was a nice paper out of Sweden or the Netherlands just in the last year or two where they were doing laser ablation of pseudopads. So dogs who have terrible interdigital cysts, the large pseudopad formation, and you really can't suture those closed because it deforms the pad. So you leave a large open wound, and they did a honey and sodium alginate dressing wound protocol, and they'd never used systemic antibiotics in the dogs, and they didn't have to in any of them, and it was 30 some dogs. So I feel like that really breaks the paradigm because all of us just reach for antibiotics right away with an open wound when you say, well, you could maybe just use honey.
Yeah, that is absolutely amazing.
Yeah, it's fantastic.
And you would think like on the paw pad, it's so much contamination, and everything like that. I truly would have reached for antibiotics as well. So just, that was the whole reason we wanted to sit down and have this conversation, let everybody know about all of these things that are out there, because like you said, there's lots and lots of products available, and keeping that antimicrobial stewardship in mind. And I've just really appreciated having this conversation with you today. You had mentioned that in preparation for this, you listened to a couple podcasts. I don't know if you made it all the way to the end and you know about our rapid fire segment.
Yes.
Yes,
but I don't. Yeah.
Do you want to play?
Sure.
Absolutely. Good. Okay. So this is our rapid fire segment. These are just for fun questions. There's no right or wrong answer. And we will start off with, would you rather practice without a microscope or without a video otoscope?
I think I'll have to go with the otoscope because you use the microscope 70 times a day.
Yep. All right. Would you rather star in a reality show about veterinary medicine or have to perform a live stand-up comedy routine about veterinary dermatology?
I think I'd try my hand at the stand-up.
You do the stand-up comedy? Awesome.
Yeah, I would give that a try.
Would you rather find out the puppy that you were just snuggling has scabies, or find out that the kittens you just examined all have ringworm?
Well, scabies for sure.
You take the scabies, don't do
Oh
ringworm.
yeah, because you can one shot cure it, just give an isoxazoline, whereas the ringworm, pain in the neck.
I will tell you, I don't know what it is, but I have never, I shouldn't even say this. I shouldn't even say it out loud, but I haven't
never
ever
say
gotten
never.
ringworm from a dog or a cat in 20 some
Wow.
years. However, my grandfather had a dairy farm in Iowa, and I swear, if I come within 10 feet of a cow with ringworm, I have it. So
Yeah, well, it's different species, but
yeah.
yeah, maybe you have some maybe you had Microsporium canis as a small child and nobody knew and
Maybe.
it went away. And yeah, you're immune.
Maybe.
Oh,
All
yeah, but
right, last question.
yeah.
If they were both still alive, would you rather treat a saber-toothed tiger for barbering, or would you rather remove like a giant prehistoric Cutarebra from a woolly mammoth?
These are great. It just opens up more questions. Like, is the tiger going to eat me? Are they sedated? Are they anesthetized?
Yeah. What kind of anesthesia can we use?
Right. I think probably the giant Cutarebra.
The giant Cutarebra. I kind of
Give me
want to
the one.
see a giant prehistoric Cutarebra, honestly.
Yeah. Like, how big is giant? Is it like the size of your head? Is it like
I think so.
the size of a car tire? Is it just like a baseball?
Well, that was all my questions. I hope you had fun playing.
Those were great. Yeah.
Oh, good. I'm glad you liked it. And again, thank you so much for sitting down with us. This is a wonderful article. For those of you at home in our audience, you can find it in Clinician's Brief at cliniciansbrief.com.
Thank you so much for the invitation.
Thank you for joining us for today's episode of Clinician's Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinician's Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.